Dr. Suzanne Jaffe Walters, and welcome to Washington Sports Medicine Institute. We're here at our new location in Texas Corner. We are a sports medicine center for excellence, and we're part of the Aligned Orthopedics platform. I am an orthopedic surgeon, I am a sports medicine doctor, and I have essential interest in pediatric and adolescent sports. Some of you are here in person. We have several people who are watching online. If you are online, if you want to go into the chat section, write in any questions or comments, and we do have a chat master who will help us address all those questions at the end of the talk. So today I'm going to talk about pediatric and adolescent sports injuries. Is sports super specialization to blame? It is estimated that over 30 to 45 million children ages 6 to 18 participate in athletics annually. Nearly 3/4 of U.S. households have at least one child that participates in organized sports. So there's a lot of kids play sports. And why is this? So sports participation is more accessible and there's increased variety. There's increasing sports specialization and more year-round and concurrent sports. There's drive for success, there's college scholarships, and the hopes of going professional. So some interesting statistics. The NCAA stats demonstrate that less than 0.5 to 1.6% of high school athletes will earn partial scholarships in D1 schools. And of these, 1% of college athletes go professional.
I think you have to leave.
Over half of children under the age of 14 who seek medical care for injuries with overuse injuries. The most common injuries that we see are sprains, strains, bone or growth plate injuries, repetitive motion, and overuse injuries, people-related injuries. And 62% of these injuries occur during practice. Over 1 in 10 will have an emergency room visit for a sports-related injury. So sports specialization versus diversification. And what does that mean? So specialization, that is an intense training in a single sport to the exclusion of others. Diversification is a general training approach that focuses on developing basic motor skills, common tactical strategies, non-specific physical training, and really just enjoyment of participation. This is less structured and involves playing multiple sports. And really, this is the way historically kids would play. So what are the pros and cons? So the pros: improvement in skills and performance in their chosen sport, encouragement of deep commitment, exclusive opportunities, whether this is private instruction from qualified coaches, ability to compete in high-profile tournaments, top-tier teams. It's a chance to attend prominent training academies, recognition, college and professional coaching scouts, and improved chances at earning college scholarships early on. So the cons: overuse injuries from repetitive strain, possible fatigue from constant traveling, mental stress from the pressure of expectation, less downtime and time for scholastics, social isolation, missing out on the benefits of replay, taking the fun out of sports, unreasonable expectations of collegiate and professional success, and the financial strain on the family due to high costs associated with athletes. So clearly, this is a long list. This does not affect every child that decides to specialize, but these are some of the issues that we need to. So many things to weigh sort of the pros and cons and how do we balance this. So the International Olympic Committee has a consensus statement on youth athletic development. They state that children who participate in a variety of sports and specialize only after reaching the age of puberty tend to be more consistent performers. They have fewer injuries and adhere to sports way longer than those who specialize early. And this makes sense that if you develop general great motor skills as a young person, that you then have the ability to develop into a more specialized athlete. So Stop Sports Injuries is a wonderful institution that was started to help make sure that young athletes continue to be young, healthy athletes as they grow into older athletes. And there's a couple of really interesting studies that they have looked at. One looks at 300 high school student athletes, and they found that highly specialized athletes were more likely to report both acute and overuse injuries. They also found a clear link between overuse injury and 3 particular risk factors: high level of sports specialization, playing their sport for more than 8 months a year, and then also playing their sport for more hours per week than their age, which then also goes back to waiting until you're a little bit older to be a little bit more specialized. And they also found that the majority of Division I athletes did not pursue early specialization, which also is an interesting finding. A couple more interesting research studies. One, it was a Major League Baseball study that actually found that the throwers that were not really, did not do early sport specialization actually had less injuries and were able to play for more seasons, which is interesting. And this was found at the Major League Baseball level. And another interesting study looking at swimming, whereas swimming in many places around the country has historically been a year-round sport, and their studies found that it actually was more important when you started competing at an early age, that actually was showed greater success moving forward than the hours in the pool that was spent as a young child. So we're going to look at a couple cases of the more common overuse injuries that tend to come into the office. So the first case that we're going to look at is a 12-year-old male, left knee pain times a year. Pain is located over the anterior knee. It hurts more with running, jumping, and squatting. The front of the knee is prominent, and that is the area of pain, and it's frequently described as swollen. So what is this? This is Osgood-Schlatter's disease, which is probably one of the worst sounding problems and one of the most common and benign things that comes into the office. This typically hits patients for around the ages of 10 to 15 years of age. We see this in males more than females. It occurs with running, jumping, or increase in physical activity, and it worsens if this area is hit, if something hits it, and or if they fall onto this tender area. On physical exam, there's tenderness right over tibial tubercle, and we can see where that little red arrow is pointing to that region. And you may have prominent swollen appearance of the tibial tubercle. Next, we'll look at an image. You can see where that white arrow is, and a little bony ossicle, which we will sometimes see if there's been irritation in this area for a while. And so treatment, rest, activity modification, ice, a patellar tendon strap is helpful in most, and then physical therapy, which is really focusing on a stretch program. This problem does tend to resolve when the growth plate closes. However, it is not a problem that has to continue to be painful until you're done growing. With proper therapy, with rest and treatment, the problems can go away. Case number 2. We have a 12-year-old male soccer player. He plays on 3 teams. He has 1 year of knee pain. Pain is never bad enough to stop playing, and over the past month has increased pain with activity. So what is this? Osteochondritis dissecans. This commonly occurs in patients who are in the age of 12 to 19, but it's actually relatively rare. It affects less than 1% of the population. It affects the knees, ankles, and elbows. We see it most commonly in the knee. Patients present with pain of the affected joint that involves with activity. Patient may have swelling, clicking, and a popping sensation. And this may also be preceded by an event, but typically the pain begins insidiously. We have some pictures up here on the screen, and we can look here on the left. So 1, 2, 3, and 4. So 1 is a completely stable region, stable lesion. This is the least serious. Here, the piece starts to become unstable. Here, the piece is loose, but actually in the region it should be in. And here we have a loose piece. And so this problem goes from being less serious to more serious with how stable that piece of bone is. On physical exam, the patient is tender over that area. And in order to diagnose this, imaging studies, initially an X-ray, and then an MRI helps to confirm. Put on the next slide. So if we look here at this X-ray, if we look here on the right side, this is the medial femoral condyle, and this looks nice and smooth. And if we look here on the lateral femoral condyle, it almost looks like a shark bite has been taken out. And that's the OCD lesion on the lateral femoral condyle. The MRI was obtained to confirm the diagnosis. And here on the MRI, where there's that little black arrow, that black region there shows that there is indeed an OCD lesion, and it's stable. It's exactly where it should be. It doesn't look loose. It's intact. There is a little bit of fluid behind it, but it's still a stable lesion, and this confirms our diagnosis. Treatment. So treatment depends on whether the lesion is stable or not. If it's a stable lesion, it's 6 weeks of a brace, no sports, 6 weeks of physical therapy, and then 6 weeks of return to sports. So this can be a difficult diagnosis, as there's typically not a specific trauma. It's insidious in onset. The patient sometimes has relatively mild symptoms. It's just that those mild symptoms have not gone away. And to not have had a major injury, to have what might be relatively mild pain and be told that we're out of sports for a minimum of 3 to 4 months is a lot to stop, certainly. An unstable lesion is a similar time frame, except it requires surgical fixation. This picture on the top right, we're looking at an unstable lesion. This end of this piece of white should line up with this. So this is the open space. And here's a picture here on the left and the right of what it looks like to put in some these were screws that were put in and that are holding the lesion in place. And then we can barely see where that lesion is here. You can kind of just see the rim around the edge. Okay, case number 3. We have an 8-year-old male soccer player with bilateral heel pain. This pain has been present for 2 years and is getting worse. It occurs with activity. The patient will limp at the end of the game. What is this? Seaver's disease, which is also calcaneal apophysitis. This typically presents in patients that are age 8 to 15. It can be either unilateral or bilateral. It usually occurs after physical activity. But as this worsens, it can occur during physical activity as well as rest. It may cause limping. Most common in running and in high impact activities. It's worse with sports cleats, such as with soccer, and if the patient has flat knees, can contribute it as well. The pain is typically the insertion of the Achilles tendon and the plantar fascia, and so patients describe, here we're looking at a foot from the side, and here this wears bright red and says pain, tends to be the center of where that pain is. It's not unusual if you have a child that just absolutely loves to play, to have that child not complain that something is hurting and just see your child maybe limping along the field playing soccer until it's just one of those things that is addressed because it's obvious. So on exam, there's tenderness on palpation of that spot that's right there on the back of the calcaneus. And the patient likely has pretty tight calves from having really tight heel boards, which is that Achilles tendon. And imaging is certainly helpful. The diagnosis is pretty obvious if there's pain right in that region. And with x-rays, part of why this happens, there's a little growth center right back here, that little kind of blackish line where it looks like these might be 2 separate bones. These are indeed connected. There's a growth center there. The Achilles tendon comes down, attaches right there where there is a growth center, and that's an area of irritation. So treatment, similar with many of these overuse issues, rest, activity modification, ice, heel cuffs, picture right here on our right, can be super helpful. Physical therapy, which really primarily is addressing a stretch program. And activity is tolerated, and really the rule is just very much common sense, no limping allowed. Okay, case number 4. We have a 13-year-old male football player who rolled his ankle during practice. He wasn't able to walk off the field, has bruising and swelling of the ankle, has pain with weight bearing, pain mainly located over the lateral ankle, and tenderness on palpation of the distal fibula. So this is a Salter-Harris 1 fracture of the distal fibula. This is a fracture through the growth plate at the end of the fibula, which is that bone on the outside of the ankle, and it's a non-displaced fracture. So this is really a clinical diagnosis more than an X-ray finding. We can sometimes find changes on the X-ray, but usually this is more of a clinical diagnosis. This almost always occurs with an inversion ankle injury. There may or may not be swelling. The patient may or may not have pain with weight bearing. Frequently, the symptoms for this can actually be quite small after that initial reaction to the trauma. This is very common in that 18 to 15-year-old patient where that physis is the weak link. This is often missed and treated as an ankle sprain, as the X-rays are very often very underwhelming. On physical exam, it's pretty straightforward. There's pain right over that area. And so in this nice picture here, there's a little looking pen drawn on the outside of the ankle here, and where there's that double line is where the growth plate is. And so this is where the fracture is generally across right there. How to diagnose this with imaging? We take x-rays, 3 views of the ankle, and again, often those x-rays are normal. This is more of a clinical finding. And treatment is a shortly walking cast, weight bearing is tolerated for 4 weeks. So moving up to the overhand athlete. We have a 14-year-old right-hand dominant male who's a baseball pitcher, has 2 months of right shoulder pain, no trauma, pain began in city state. So this is little leaguer shoulder. The mechanism of injury is repetitive torsional and distractive stresses at the physeal or growth plate. This occurs during pitching. This tends to happen during the late cocking and deceleration phases, and pitch count is really important to help avoid this. Symptoms: patient has diffuse shoulder and arm pain when throwing, worse than the late cocking or decel phases, and pain resolves with rest. On physical exam, there's pain right over that area in that lateral proximal humerus. Pain is reproduced with shoulder rotation, and the patient generally has glenohumeral internal rotation deficit, meaning they're just tight back in the shoulder. So we start with x-rays, and this can be very obvious on x-ray. So if we're looking here on the right, this is the shoulder joint right here. Here we're looking at the growth plate, which is physis, and this looks, we're looking at a 3D structure in 2D, and so it is not a completely straight across structure, but it looks like the amount of the lines here are sort of symmetric coming across the same amount of wideness. And so now look here on the x-ray on the left, and look how different this looks here, about how wide the black region between the bone here and the bone here, how much wider that is compared to here. And this is confirmed with an MRI, which we look down here, and all of that white is all the inflammation down here, which looks definitely different than when you're looking at the growth plate in this region over here. So treatment for this, also not fun for the athlete, cessation of throwing and rest, physical therapy and progressive throwing program. And actually, one thing before we move on, that I just wanted to mention that is super important for returning to sports after this is not just allowing the patient to rest and feel good, and then just sending them right back to do exactly the same things that the athlete had done before. That I think that's just setting the patient up for having this constant, play, come out, play, come out, play, come out. And there's generally a reason why this happens, and it's almost always looking at the throwing mechanics, that maybe their kinetic chain isn't working. As they're aging up, they're expected to throw harder and faster, that too much of that force is going across the upper extremity. And so having them working with someone, in addition to just having the pain go away, making sure their arm is strong, but making sure that they're using that whole kinetic chain and that they don't have hip weakness or any core weakness, and looking at how that whole kinetic chain is working together. And so set that athlete up for success as they're returning back to sports. Another baseball issue, 12-year-old male, elbow pain, baseball pitcher, does not keep track of pitch counts, just finished 2 weeks of baseball camp, continuing to pitch despite arm fatigue and pain. What is this? So now we have little league elbow. Similar pathophysiology, but this is with the aspect of this that causes the issue with elbow. And not appropriately engaging the kinetic chain with too much force across the body. So there's 3 potential sites where the young player can have little league elbow. Primarily in that medial aspect of the elbow. It can be medial epicondyle stress fracture, the ligament, the UCL can get strained. If the patient's younger, though, it's more likely to create an avulsion fracture, and it can also create strain in that flexor pronator mass. I would say most commonly is apophysitis within that medial epicondyle. It's the most common area of athlete. So risk factors: greater than 80 pitches per game, more than 8 months of competitive pitching per year, which has been a common theme, fastball speed greater than 85 miles per hour, and continued pitching despite arm fatigue and pain. And that's also a really important factor. with multiple sports and multiple body parts is continuing despite fatigue and pain, and knowing when to take a break. So symptoms: elbow pain and throwing. And then the result of this is having decreased throwing speed, accuracy, and distance. On physical exam, there's tenderness at the medial elbow, there's pain with pelvic stress, and there may or may not be instability in the elbow. Again, X-rays and MRI. X-ray is the first modality. We may show some physeal widening. Right here, this little piece of bone here is the medial epicondyle. Believe it or not, that is part of the same bone right here, and it should be much closer. This has been pulled off. And this MRI is of a different patient, but it does show this whole region in there. All of this white is inflamed, and it should, this black area there should be closer to the black area there. You can also see fragmentation in the bone if there's been irritation in that area for a while. Treatment, again, very similar theme here: rest, physical therapy, and a return to the throw program. And then in addition to making sure that the kinetic chain's been addressed, that overall global strength has been addressed, that the throwing mechanics are good, also being aware of patient moving forward. This is rarely an operative issue for a young person. If just rarely, we'll just mention that there are two potential operations if this is not resolved in conservative treatment. And our last case, a 12-year-old female. She's a level 9 gymnast, 20 hours of practice a week, 2 months of increase in wrist pain. What is this? So gymnast wrists, great name, right? This happens in gymnasts. It's technically distal radial physeal stress reaction. And so that's essentially a stress fracture on the end of the wrist. This happens when there is more load to the wrist than one is to be expected. You know, we were not necessarily meant to be walking around on our hands, and there's a lot of demands on that wrist that are required of these young gymnasts. Repetitive stress causes inflammation of a growth plate of the distal radius, and microtrauma can lead to premature closure of devices. So this is a really important thing to address. Symptoms: chronic radial side of wrist pain. On physical exam, there's tenderness right over that area. There may or may not be swelling, and the patient may or may not have the ability to kind of flex and extend the wrist the way they, the other side would, or the way the wrist did before it started. Imaging, again, we start with X-rays, AP and lateral wrist. And there's the potential for seeing a widened growth plate. And this can be pretty dramatic. If we're looking right here, this should be a nice small line, and see the white starts here, and it should look more like this growth plate right here. This is pretty wide, and the MRI is obtained to confirm the diagnosis here. In this case, we really didn't need to confirm that here all of this white shows inflammation around the growth plate. One of the risks, in addition to worrying about not having growth at the end of the wrist, if this one bone closes and this bone doesn't, then all of a sudden your hand is heading off in the wrong direction, and that's called variance. Then that MRI is obtained and confirm the diagnosis, and can also let you know if there's early bridging and that growth plate is starting to shut down. So treatment is non-operative. Anti-inflammatories if the patient is that painful, but typically once the treatment really is putting the patient in either a cast or some sort of fracture brace and shutting down this region. I recommend 4 weeks. Literature states anywhere from 3 to 6. I found 4 weeks works well. I don't think NSAIDs end up being necessary, because typically once that patient is weight bearing on their upper extremity and completely immobilized, that pain is gone. And then operative intervention might be necessary if that growth plate starts to grow together and is no longer open. When the other growth plates in the body are open, then a resection of that bridging bone can be necessary. And if it's too advanced to be taking out those bridges, and sometimes that other growth plate might be shortened as well. With that being said, the outcome is generally good with this. It's just really important for early recognition and treatment. So now that we've kind of gone over some of these cases of overuse, just kind of getting back to specialization. What is the right answer regarding sports specialization? And I think the important thing is finding a balance, and there's certainly no right answer for everyone. Certainly delaying sports specialization until mid to late adolescence is smart. Taking scheduled breaks is a good idea, and really it's about being a good observer and knowing your kid and or knowing your patient. And again, there's every kid is different. There's no right answer for everybody, but being aware, is your child less enthusiastic about going to practice? Are they complaining more about, things that are hurting them? And are they not having time to do their schoolwork? Are they annoyed that they don't get to go out with their friends? Or are they thriving and just really enjoying all of the increased activity that they're doing? And I think it's just important to be aware.
Great talk.
Thank you. Well, thank you for being here.